All right, everyone. Happy Thursday. Today is a first. It's the first time we have our beloved Aaron present discussing. And forgive me for that slip, though. I think if you've been around, you'll know why I made it happen because Aaron has presented many a case. I think we're nearing double digits, but it's his first time discussing, and I'm going to say it over and over again because he's already told me that he's very anxious. And I'm a believer that the only way to really deeply address anxiety is just to pop the balloon. So very excited for you to pop that balloon, Aaron. Very, very grateful for all that you've done in this space. And I have a sneaky suspicion this is just the beginning of a absolutely fantastic career. I'll hand the mic to you to say hello, and then we'll thank everybody else who's making this happen.
Hey everyone, I'm Aaron. Thank you, Robbie, for all those kind words. I guess I just started in the academy like in October, and I've learned so much from this space. So finally excited to do a discussion with you here on Thursday VMR. Yeah, I'm really a little bit nervous, but I'm excited for Robbie's case, and yeah.
Yeah, the nerves will fade, I promise you. We'll check in 20 minutes or so. You'll see your heart rate will be much, much better because we're in for a treat for sure. But first, let me shine the light on the two people who are making the session happen. First, Mohammed, who is scribing, and then Vinny, who is doing teaching points. I'll hand the mic to you guys.
Hello, everyone. I am Muhammad from Iraq. I'm excited for today's session.
Hey everybody, I'm Vini. I'm super excited for our own discussion and wish you the best of luck.
You're so kind, Vinny. Last but not least, oh my gosh, Rabih, I'm loving this new case presenter vibe that you have. We're learning so much from your cases. I'm very excited for version 1000 probably or something near that. I'll hand the mic to you.
Oh, absolutely. It's such a pleasure to give back to this community that's just given us so much learning and a space to sort of learn as well and teach as well. And extra special treat, Aaron, you've presented me so many cases. This is a chance for me to give back to you. So to present on your first discussion. So you'll knock this out of the ballpark. You'll do fantastic.
No doubt about that. All right, shall we rock and roll, team? Let's do it.
Absolutely. So I'll put the aliquots in the chat so the scribe can follow. So today's case is we have an 18-year-old female lacrosse player and has a history of nodulocystic acne. And she comes in initially, she's having this relapsing and remitting painful skin lesion on the thigh. And this has been happening over several months. The lesion's described as being erythematous, progressively enlarging. It was initially thought to be a reaction to isotretinoin, which was discontinued, and then she was transitioned to clarithromycin. So after this medication change, she is then developing a new onset chest pain while playing lacrosse, and she had to then withdraw from the team. This pain is described as 8 out of 10. She's in the emergency room, not radiating anywhere. She's having some dyspnea. There's nothing that's really making it worse or helping with it. It did come on when she was playing lacrosse. There's no associated fever. Oh, sorry, there is mild dyspnea, but no gastrointestinal symptoms. Never had such an episode before, so this was the first time she's had it. And I'll stop there for discussion.
All right, Aaron, if you were starting feeling the nerves, I can't imagine what you're feeling right now. Oh my gosh, what a tricky case. And part of my job here is to just acknowledge that what happens when you hear an HPI many times in real life is you realize that the story is building upon itself and walking in a straight line and you can really make iterative progress. And I will just acknowledge that it is impossible to come up with a cohesive narrative with such a murky story, right? And so there's nothing that anyone can do apart from just acknowledging the inherent uncertainty. And I think the first key decision that your mind has to do is to decide where do you start? Do you start with the chest pain or do you start with the thigh lesion? And I'm really curious how you're debating that in your mind and what you're inclined to start your analysis with.
Yeah, so honestly, for this one, the reason why she came to the ED in the first place was this new onset chest pain, and I feel like I'm more worried about that rather than anything. I feel like the history of the acne with the isotretinoin and the clarithromycin story, I can put that in the back of my mind as a later thing. But right now, I want to focus on this new onset chest pain and make sure she's not, in any acute life threats or emergencies,
Yeah.
especially since it was happening during lacrosse, which is like exertional. So just want to rule out all the life-threatening causes first, and then if the initial workup is all right, maybe we can start to tie in this acne history.
Yeah, superb. I'm right there with you, and I think my area of focus is the same as yours, and I'm really curious how are you thinking about um I think the modifiers are her age, and so how does her age influence your calculus here?
Yeah, so for her age, it's she's an 18-year-old. I'm assuming she has no other past medical history. I'd be interested to see if she did. So I wouldn't really be thinking anything like an MIPE or anything like that. So it's I just want to make sure though that she's not one of those strange cases that actually has anything acute like
Yeah.
that. But given her age, I'm not really thinking of the usual like MIPE dissection things. So not really too sure.
Yeah, I think that, the reality is that when we take care of much less a much lower number of people with chest pain who come into the emergency room who are young. So you just have to acknowledge that the N is exceptionally low. And so the question is the N of sinister diagnoses proportionally low, or is it skewed in some way? And this is I'm trying to sort of get out complicated math through words, but if we just acknowledge the fact that, let's just make up a number. One tenth of 1 out of 10 people who come to the ER with chest pain, 1 out of 10 people who come to the ER with chest pain are young. Such a small number. We diagnose a very, very small number of young people with serious things. And is that because a small amount of young people come to the emergency room with chest pain? Or is youth protective? And I think we have to really think through that. And so I will say that a young person coming to the ER with chest pain is already a rare event. What happens to those people who actually do come to the emergency room with that symptom complex is an interesting thing to think through and mull over. And it turns out that the rate of sinister diagnoses in patients who are young who present with chest pain is not exceptionally low. And what you're seeing simply is the selection pressure of youth making it much less common for those patients to present in the emergency room in the first place. And what's interesting about what's happening with the metabolic syndrome epidemic is that you're seeing the same diseases that affect older adults happening in younger and younger and younger people. And so you have to be vigilant to that possibility, but also a whole range of diseases that tend to affect only young people. So when a patient with congenital heart disease sneaks by and presents in early adulthood, it's the perfect time for it to do that. Um, when a patient gets traumatic complications of the chest, it's a perfect time to do that. When patients get autoimmune diseases that affect their thorax, it's the perfect time to do that. So I think it's an interesting thing to ask yourself about an 18-year-old who develops ACS, super rare, um, in all comers. But if you select for the people who are electing to come to an emergency room, the odds aren't so stacked against them. So I worry when people like this show up to the emergency room because I worry that we don't take their symptom complex too seriously. But gosh, I just emphasize that the massive selection pressure really makes me pay very close attention to what's going on. So yeah, I think as you said, we have to rule out the scary stuff. And then I think be open to very unique conditions that only affect younger people, congenital heart disease, autoimmunity, so on and so forth. So yeah, let's stay focused on the chest pain and we'll see what the rash does for.
Absolutely wonderful comments. Yeah, I think I read about this that a lot of young people come to the emergency. I'm like, you're too young to have an MI and get discharged and then suffer a lot of adverse events. So, absolutely wonderful comment regarding that. Moving on, so there's a past medical history of nodular cystic acne, social history, some occasional marijuana use, medications. There was this isotretinoin, which was then transitioned to clarithromycin. No other medications. No. Some people are asking about OCPs. No OCPs. No family history of coronary artery disease or premature MI or structural heart disease in the family or sudden cardiac death. And moving on to, I'll give you the exam. So on vital signs, temperature 38.1, respiratory rate 16, pulse ox 99% room air, blood pressure 118/75. And on exam, there's nothing remarkable. The lungs were clear, generally looking to be in distress with this pain. And on her flank now, she has this indurated erythematous plaque, which is about 13 by 5 centimeters. So previously she had it on a thigh, now she has it on a flank. And I'll share a picture of this. I actually have the picture. It's an old case, but let me send a request. And so this is the 13 by 5 centimeter erythematous plaque. I'll stop here to let you discuss.
Oh my gosh. Yeah, Aaron, maybe we when the rash is staring at us in such a prominent manner, it's hard not to pay attention to it. What are you thinking with this?
Hmm. Well, this rash sorry, Ravi, if I missed it. Is this rash new, this one on the back, or has this also been there for a while?
Yeah, this one's a new one.
Okay. Yeah, it's very large, I would say, and then it looks like the edges are a little elevated, and then the middle of it is a little less like hypopigmented. I guess I would ask, I don't know, I'm not too sure actually, but yeah, the middle of it looks a little more hypopigmented than the edges. But there doesn't seem to be like any active like bleeding or discharge around it, but not really too sure what to make of it. I don't know. What are you thinking, Dr. Robbie?
Yeah, I'm right there with you. I think that when I look at this rash, I'm concerned. It's so extensive, and then there's some ulcerations and heaped up borders. So I can tell this is probably not a benign skin condition, which is the vast majority of cases of the rash. I'll tell you that I think when I think of a rash, I think of a very simple exercise, which is this just a dermatological problem, or is this the tip of the iceberg? And when we're having chest pain and fever, I know for a fact that I can make a lot more progress on what's happening as an internal medicine doctor with that concern, and then layer in her rash. But I think it's very easy now to say that this rash is not a bystander. It needs an explanation. And many people who have a systemic illness, fever, and chest pain, they get rashes for a wide variety of non-specific reasons. So they get fever rashes, drug rashes, viral exanthems. This is a rash that has a tremendous amount of specificity based on its size and the large heaped up appearance. So what would I do in real life? I'd be like, oh gosh, this is not an innocent bystander. I have to explain it, and let me see what progress I can make with the skills that I'm trained at, and then see how we can loop this rash back in. So if you were to do that exercise, Aaron, when you're like, okay, I'm gonna think about her chest pain and her vitals, what progress can you make in that domain?
Well, I was kind of surprised that she's febrile. I wasn't really expecting that, given it was just like it sounded like an exertional chest pain. So now that there's a fever and then chest pain, with all these rashes, I can consider infection or at least just a systemic inflammatory process going on, not necessarily infection. So I guess that's kind of the progress I've made so far.
Yeah, it's pretty rare, Aaron, to have fever in a context of chest pain. And so, if when you go back to those life-threatening emergencies that you listed or thought about, you didn't explicitly list them, but you're thinking about it, ACS, pulmonary embolism, aortic dissection. You ask yourself, which one of those things carry or bring with it inflammation or a fever? What do you think about that?
I feel like more uh MI and PE, less dissection
Yeah.
with the, yeah.
Yeah, and would you say that in an MI or PE that you see a fever commonly, or it would be an unusual manifestation? What do you think?
I don't think they usually present with
Hmm.
fever. Yeah.
Yeah. Yeah, I mean, these are mechanical things, right? There's a blockage in your coronaries or blockage in your pulmonary artery. And so some people invoke the idea that you can get low-grade fevers as the body's response to this blockage. But I find that to be a suspicious initial diagnosis to make. We were humbled a few times on the VMR where patients had STEMIs and PEs that produce a low-grade fever. But you definitely want to think of that as an end-stage diagnosis, not initially. And so what do you think of what do you think how does the calculus change, or what additional diagnoses do you think of when somebody has fever and chest pain?
I mean, like, just coming to mind, like, one of the most dangerous things
Yeah,
is probably like mediastinitis, but very unlikely here given the history, but I'm not too sure. That's like just one of the danger things I think of with fever and chest pain, or like a raging pneumonia or
yeah,
things
good.
along those lines,
Good,
or like cardiac infections like myocarditis,
good.
things like that. Yeah.
Excellent. Yeah, I think it's hard to come up with that DDX, right? It's not something that's very common. It's very, very unusual to have fever and chest pain in general. And I say that because the most common cause of fever in the chest is a pneumonia. And unless you have a pneumonia complicated by pleural irritation, you don't really get pain. So I'll just say this. Um, Chest pain is either an issue at the surface of the chest, or, but maybe I should say it another way, actually. Just sort of, I'm trying to vocalize why fever and chest pain is rare, and it's a rare space. And I think perhaps the way to really understand that is to understand that the lungs themselves don't hurt. And so there's very few situations where the lungs themselves would cause pain. And at the same time, the lungs are the most common source of a fever. And therein is that paradox. When you have fever and thorax, you think lungs. But chest pain is very much not a lung problem. And so, how do these things overlap? They overlap in a very, very unusual way. You could easily imagine how somebody has a superficial infection at their chest wall, and that produces a febrile response, but that is usually evident at the surface. So I hope by following this conversation, you're seeing that the lungs are a very unlikely source of fever and chest pain. A very plausible source is the surface of the chest wall, right? But you'd be able to see that. So if you're thinking fever and chest pain and you know it's not the lungs and you are looking at the chest wall and you see it's fine, where is the fever coming from? And I think that goes to show you that odds are the inflammation is coming from a structure that's beneath the chest wall, but outside the lungs. And so, unfortunately, Aaron, every single structure that's been between the lungs and the chest wall is not a good structure to have a fever coming from. And that's why this combination of symptoms is very, very ominous. So, if we list the structures between the lungs and the chest wall, you can come up with the pleura, right? That's probably the most common source. You can come up with the mediastinum, as you just said. You can come up with the pericardium. You can come up with the myocardium. You can come up with the endocardium. None of those are great. And so I think this is why when I asked you, hey, when you think of fever and chest pain, you were like, yeah, you should do that because it's rare, it's unusual, and if it's truly the actual problem the patient has, it heralds not so great things. So this is, I think, my first time trying to vocalize this issue. So I'll definitely fine tune it over time. But I'm curious what questions you have about that because I think we have an opportunity to make it a little bit more clear for everybody.
I guess my question now is like why is she having this
Yeah.
pain really? Like
Yeah.
if it is turns out to be the pleura or those other structures, like why? So
Yeah.
I mean she is like a young female. I guess she fits the picture for like an autoimmune disease, but
Yeah.
I don't want to anchor on that at the
Good.
moment. I just really want to see our initial workup and if that brings anything. But I'm
Agreed.
keeping that in the back of my mind.
Agreed. Yeah, and I'm right there with you. I think that why she's getting this is really, really important, and it's hard not to ignore the skin as a potential clue. Do you just to make sure that everybody's clear on it? Do you have any holes in understanding of why fever and chest pain is such a rare thing, or did you feel like you were able to upload that spiel?
I guess, yeah, it kind of makes sense. Yeah, with the chest pain, the other structures aren't really innervated as
Yeah,
well.
right,
So
right.
uh, when there's irritation to the pleura and the pericardium, that can really cause symptoms. But
Exactly.
yeah,
Exactly. Yeah, I'll say it one more time. The um, lungs don't cause chest pain, but fever usually means lungs. Most common cause by far. And so if the lungs are not on the hook for the cause of a fever because the patient hurts, you have some work to do. The most nice answer would be the patient hurts because they have an infection on the chest wall, but usually you can see that. So on your list of things in the chest, you've crossed out the lungs because they don't hurt, and you've crossed off the chest wall because you can see it. So what are you left with? Everything else in the middle, and none of those things are good. All right, I'll see what Robbie has in store for us next.
Fantastic guiding through this case, Rabih. Aaron, you're doing really well. So let me give you the next piece of data. So there's some labs. The white count was 9. There was the differential, if I remember, neutrophils were elevated in this case. Hemoglobin 12, platelets 300. Chemistry essentially normal. SED rate 51, CRP 28. EKG, which was asked for. So no ischemic changes. Troponin initially was normal as well. And I'll stop there for discussion.
Awesome. Wow, what a fascinating case. Aaron, what progress do you think you made with this?
I mean, I don't really, it doesn't look like there's an infection with a white count of 9. I guess that's normal. The hemoglobin of 12, that's also fine. And the platelets are also fine. So nothing, I guess it's just a pertinent negative now that there's like no acute leukocytosis or thrombocytopenia or anemia or anything to make me think of
Mm.
any issues in the blood causing her symptoms at this moment. Then for the normal chemistries, I guess that's just reassuring as well. The ESR and CRP, I believe those numbers are a little bit elevated.
Yes. Yeah.
Um, I'm not too sure how much progress that like gives me because
Yeah.
I guess I was expecting that as well with the fever and the inflammation,
Right.
but I'm not too sure. The normal EKG also reassuring that it's not ischemia,
Yeah.
but yeah, I guess we is there a chest X-ray as well? Oh, the
Yes.
chest
Yeah.
X-ray was clear.
Yeah.
So I guess from
Yeah.
here we've kind of ruled out the most common life-threatening causes, and I guess now begins the investigation of what is this actually, you know?
Yeah.
Yeah.
I feel bad because I told you by 20 minutes we'll have your nerves calmed because I usually you get a sense of what the issue is by the 20 minutes. I have no idea where this problem is. But I think that's actually fun to just vocalize that it's actually very difficult to know what it is. And I think what you did with the labs is you're like, this person isn't that sick, right? Essentially, if I may take the liberty of summarizing what you said, this patient could have had a white count of 30, in which case I think your glasses would be through the screen, but you're like, I'm not sure what to do with it. So let me just ask you one hypothetical question, Aaron. So we have a fever of 38.1, which is actually very mild and low grade. What do you think you would have done if the inflammatory markers were normal? How does that help you think through the fever with completely normal inflammatory markers?
Then hmm, fever with normal inflammatory markers.
Yeah,
I guess I would
just
find that
reflex.
a little odd.
Right.
Um, why is your temperature so high, but you're not actually inflamed?
Exactly.
I'm not too sure. That would be a question that
Yeah, I
I'd
mean,
try to ponder upon.
yeah, you don't need to ponder about it because you doubt the validity of the fever, right? Anytime you have a weird number, especially if it's low grade, you're like, is this fever real or not? And I'll tell you, the number of times we get fake fevers is super common. And so I think the value of the inflammatory markers is hey, don't ignore that fever. So I sense that you were like, hey, I think this person's not that inflamed. And you're right, they don't have a fever 102. And so I think the presence of the inflammatory markers just says, hey, don't ignore that fever. It's real. Pay attention to it. So this is where I think we really have to iron out this framework of fever and chest pain because we know this patient isn't super inflamed, but they are. Not enough to mount a high white count, but enough to mount an ESR and CRP. So we have to figure out where the heck is this inflammation coming from? So let me vocalize the list again of structures sandwiched between the lungs and the chest wall. And maybe, do you have a paper in front of you? Or are you writing? Yeah, okay. So tell me if you agree or disagree. Pleura, pericardium, myocardium, endocardium, and then mediastinum. And you can divide the mediastinum into mediastinal mass or mediastinal vasculature, like the pulmonary artery or the aorta. Cool? So now we got to take the data that we have already and ask yourselves, what can you cross off? Or at least cross off with a pencil, not a pen. What can you cross off based on the data that you have about where this is coming from? What are you thinking?
I mean, based on the chest X-ray that didn't show anything, I guess we can cross out the pleura,
Beautiful.
but I mean, it could probably still miss if there was like something tiny there, but
Yeah, agreed.
um,
Agreed.
less likely given the clear X-ray. The pericardium, I mean, I guess there would be cardiomegaly if it was obvious on exam on the X-ray, if it was like a very large effusion or anything
Right.
going on there. Also, a large mediastinal mass would probably not be seen on an X-ray.
Yeah.
Yeah. And then for the vasculature, I think we still need more data for that, but yeah.
Yeah. Beautiful. Okay. So if you wanna literally, I completely agree with what you just did. So go ahead and do that on your list and then tell us what's left.
We basically have the myocardium, the endocardium, and then still the vasculature.
Beautiful. Okay. So
Yeah.
now I want you to be the doctor in real time. What additional data would you want to try to get for this patient in the ER to clarify these hypotheses that you have?
I mean, for the vasculature, I mean, we can do more imaging with
Yeah.
an CT angio or something
Yeah.
like that, or maybe an echo even to further investigate.
Yeah.
Uh,
I'm
yeah.
I'm about to show you a picture that reinforces what you just said. I'm trying to find your zone of growth because you nailed it. So now the question is, what do you want first?
I guess first would maybe, I mean, I feel like a CT would be faster, but then an
Beautiful.
echo would show if there was like an acute effusion or anything that would need to be
Right.
acutely treated. So maybe
Uh,
focus bedside just to check.
Good. Good.
Yeah.
Good.
And
So
then yeah.
so you would use your POCUS to help you triage which one to do first. Um, Ask yourself of the diagnoses you just listed, myocarditis, endocarditis, and vasculature, which one is the most deadly?
I mean, if it was like an acute vascular thing, I'd be more concerned about that. But
Right.
yeah.
Yeah, I don't really care about the endocardium or the myocardium when I'm thinking about the aorta. Yeah. Like think of the number of cases we've seen here with myocarditis and endocarditis. They matter when somebody's in florid heart failure, but when somebody's not in heart failure, you can take your time. If the aorta is on your mind, oof. So here, let me show you a picture of essentially what you just said. The title is inflammatory dyspnea of the schema, but it can be anything in the thorax, right? So this is how you get to the bottom of it. You get an X-ray and you see these things. If you don't see them, these are the things you can see on CT, and these are the things you can get on echo. And if you have been part of the academy sessions where we've had an epidural abscess present with chest pain, you'll be humbled forever. Um, so I think that this is the journey I would go on. And Aaron, the reason I would get a CT contrast and not an echo is because I can see a large effusion on this CT. And gosh, I think her skin rash is not irrelevant. And if you wanted to get nerdy, we would probably get nerdy and think about how they connect. But if you're in real life taking care of this patient, you wouldn't get nerdy now. You would first understand what's happening in her chest and then get nerdy. So, any questions about any of that?
No, I think that makes sense.
Yeah.
We just want to make sure the vasculature is all right, and then we can go from there.
Yeah, exactly. Isn't it amazing? I didn't teach you anything new in terms of knowledge. Like you had all your knowledge in place, but this is the power of going through cases, is it allows you to structure it in a more practical way. So now going forward, next time you see fever and chest pain, you'll be like, oh, that's unusual. I know which structures to invoke, and now you know which tools to use. All of these data, all of these pieces of knowledge you had, but the beauty of clinical reasoning is it allows you to sort them in a way that allows you to actually take care of a patient in real life. So kudos to you for being able to do this in real time in front of a public public audience. It's not easy, but I think we're about to get clarity on the case, or at least some, things will hopefully start to move in a linear way as opposed to the constant chaos we've been juggling. But this is the real life care of a patient who's ill. All right, Mike, to you, Robbie.
Yeah. Absolutely wonderful discussion there. I just love how you kind of led the thinking, trying to highlight what is going on with this case. So some more data. There was like you mentioned, this patient with chest pain. So chest pain was front and center, and a stress test was done to see could there be any underlying coronary artery disease. So there was upsloping ST segment depressions in the infralateral leads consistent with myocardial ischemia. An echo was done as well, showing normal LVF and a small eccentric jet of aortic regurgitation, no pericardial effusion, and no vegetations. And I'll stop there for discussion.
All right, Aaron, we got some more data. What do you think?
Interesting, very interesting that she actually did have some ST depressions on her stress test. I wasn't expecting that, as well as the aortic regurg. So the question is like, why is she having ischemia, like infralateral? So I'm guessing that's the like PDA or one of
Mhm.
those arteries. And then the
Sure.
aortic regurg, like
Sure.
why? What like does she have tissue disease that's doing that, or is there like an infectious or inflammatory process there with
Yeah.
her valve? But then the fact there's no vegetations or effusions, a less likely infection, and yeah, maybe not too
Very good.
sure, but it's very interesting.
Very good. Yeah, tremendous progress. So again, round two of trying to help you organize your knowledge. I don't think I can teach you anything about coronary disease. You even laid out the anatomy very well, but maybe we can study aortic regurg. And I will tell you that there's two things that can cause aortic regurgitation. The first is there's something wrong with the valve itself. So, Aaron, when you have fever and aortic regurgitation, you have to think endocarditis, endocarditis, endocarditis. So before you get esoteric, that blood cultures are key, culture negative endocarditis, and so you have to think about something wrong with the valve for sure. But Aaron, the valve sits in the aorta, right? And so something that can influence the anatomy of the aorta can cause regurgitation as well. So if you take the aorta and stretch it out, the valves won't co-opt anymore. So whenever you're thinking about regurgitation for any valve, you have to ask, is it an intrinsic valve issue? Or is it in the chamber that is holding the valve? So the most common cause of mitral regurgitation is not something wrong with the valve itself. It's that the LV has dilated because of heart failure, and then you get functional mitral regurgitation as a result of that. And a valve surgery does not fix functional mitral regurgitation because the valve itself is not the issue. So here we have to decide, is this an intrinsic issue of the valve? Or is this something with the aorta? And so now this is the leap that we have to make together, okay? So you have aortic regurgitation along with coronary disease. And I want you to try to imagine what Robbie's telling us. He's telling us that there's something wrong with either the aorta or the aortic valve. And the clue we have to figure it out is there's also issues with perfusing the coronaries. So does the issues perfusing the coronaries help you make an educated guess as to whether this is a valvular issue or an aortic issue? What do you think?
Um, um, I'm guessing. like with the decreased perfusion of the coronaries and the fact, I'm guessing this is a new aortic regurg in the setting of her fever and chest pain and all her symptoms.
Yeah.
I'm thinking more if it's like yeah, I am agreeing with the endocarditis picture, but yeah, I'm not really too sure. Maybe it is an aortic issue.
Let me guide you by asking you one question. Where do the coronary arteries originate?
From the as the aorta, or well, from the yeah, like the beginning of the aorta, or
Right. How
yeah.
close do you think the beginning of the aorta is to the aortic valve?
Um, Close. Like a
Yeah,
little, very
very
close.
close.
Yeah.
Very, very close. So if you're saying I have either something with the aortic valve or the aorta,
Mm.
a clue is that there might be coronary disease. You can think of a lesion in the proximal aorta that affects the valve and simultaneously affects the coronary ostia. Alternatively, you can have an endocarditis that flicks off into the patient's coronaries. So if you're making an overlap with coronary ischemia and aortic regurgitation, the overlap can be that there is a lesion in the proximal aorta or that the patient has valvular disease with thromboembolism. And so I think how you make progress in this case is very, very difficult because it's very tempting not to cath the patient who has this uh, perfusion deficit, but you're only obligated to cath somebody if they have acute coronary syndrome. You can take your time to figure out what's going on if they don't have ACS. And so with a normal EKG and presumably a normal troponin, you can take your time. What I would recommend in this case is that you pursue the common denominator of coronary disease and aortic valve disease, a proximal aortic lesion. And this is why chest pain in young people is so scary because aortic dissections are things that we don't think about in adult medicine because they usually occur on top of a dilated chronic aortic condition. But aortic diseases disproportionately affect younger people without a dilation in the aorta. So often, if this patient, Aaron, had a massively dilated aorta on her chest x-ray, we would have gotten a CTA a long time ago. Um, but many aortic diseases in younger people happen on top of a normal anatomic aorta. So yeah, I'd really, really worry about her. I worry more about her aorta because we have aortic regurgitation and potentially aortic occlusion of her coronaries. Questions or reflections about that?
I think that makes sense. The great way to explain that with the proximity of the
Yeah.
coronary, the opening of the coronaries and the aorta. So disease in that area could definitely affect both. So yeah, it
Yeah.
was good to connect that anatomically.
Yeah. Awesome. Alrighty. Worried about this patient, but let's see what Ravi has next for us.
Okay, wonderful discussion so far. Yeah, you guys are absolutely on point. So the next bit of testing that was done, blood cultures, autoimmune studies, all came back negative. Imaging was done for, so the X-ray was initially negative. The CT that was asked for, there was a coronary CT angiography image that was done, which shows stenosis of the left main coronary artery and wall thickening in the aortic root and descending aorta. And I'll give you an MRI. So also a contrast enhanced MRA was done showing narrowing of the juxtarenal aorta and left renal artery. Post-contrast MRI shows enhancement in the adventitial side of the aortic wall and peri-aortic fat and in the left renal artery. And I'll stop there for discussion.
Oh my gosh. Oof. There's a lot to think about here, Huron. I think it's probably the perfect time to do a maybe a 5 minute breakout room so you can nerd out and see what progress you can make. And I think we're about to get very, very nerdy. So if you'll indulge me, Aaron, I'm really curious if you wouldn't mind, because this has been a really tough journey to clarify this problem. And I can't imagine what it must like in real life to figure out that this young person has something wrong in all these areas. I'm really curious if you wouldn't mind just taking a moment to sort of re-emphasize the things that you learned today that were new to you, because I think there was a lot of like friction to this arriving at this problem space.
Yeah, so I mean, initially, with the first aliquot, this was just a young female, presumed healthy, who has this history of skin lesion, which was thought to be acne. But then when on her exam, she was febrile, and she still had this chest pain. So we had that discussion of fever and chest pain, which was interesting. We were able to localize the structures that could cause her symptoms, including the pleura, pericardium, myocardium, endocardium, the mediastinum, which included masses and vasculature such as the aorta. On the initial workup, the most were unremarkable, but the elevated inflammatory markers suggest that this indeed is an acute inflammatory process, along with her fever. And then the echo and the stress test with the new aortic regurg with the ST depressions in the infralateral leads are suggestive of proximal aortic disease that could contribute to the coronaries being affected as well. So that was interesting to think about and like solidify in my mind. And then with this new findings on CT and MR, I guess we can figure out what's happening.
Yeah, you learn like a sponge. It's unreal your ability to absorb information in real time. Oh, that's awesome. You're so well prepared to tackle complex issues. Yeah, I have nothing to add to that. That was a beautiful summary. All right, so we'll do a breakout room for you. Finally, get a little breather, relax from the stress of this case, and we'll reconvene in a few minutes. Okay. All right, welcome back, everyone. I hope you had fun nerding out about this really fascinating series of images. So, Aaron, you had quite the number of people in your group. What did you all talk about?
Yeah, so Catherine initially mentioned, we're just going back to the beginning with the clarithromycin, initially thinking it was like an SJS-10 picture, but didn't actually turn out that way, especially after all the imaging findings. And then Austin was talking about helped me try to localize uh, where the disease is. So we were able to come up that it's a large, it seems like a large vessel vasculitis slash multifocal type of inflammatory process. And then we were just going through the buckets of if this is an infection, what other causes are there, such as autoimmune. And then we mentioned Takayasu's and SLE, though less likely with the initial negative autoimmune workup. And then, yeah,
Yeah.
so that's the progress we made.
Yeah, I think it's tremendous progress. I think, you started from such a nebulous landscape to saying, hey, this person has inflammation of her aorta, and the inflammation is evident on the CT and the MRI, and so you update your problem representation to aortitis. And I think this is a rare space, but there's a couple of CP solver schemas on it, and it emphasizes that autoimmune diseases are by far the most common, but you want to make sure you don't miss any infections. Um, and the number of infections to think about is many, but I'd say the most important one to test for universally in everybody is syphilis. Um, but once you are in the world of autoimmunity, the by far and away the most common cause of aortitis in a young woman is Takayasu's aortitis, and I would venture to say that her rash is a powerful clue to this diagnosis. Um, the presence of erythema nodosum like rashes on the spectrum of neutrophilic dermatoses is very well described, and in fact, so well described, we've seen it on VMR with Unmol having presented a case very similar and a very similar rash like that. So I think you could biopsy the rash to see if it is in fact neutrophilic dermatosis to support that hypothesis. There's no additional diagnostic test for Takayasu's apart from recognizing the radiographic pattern and ruling out other diseases. But I think prompt immunosuppression is so key for these patients because they get a whole variety of complications, including, as you're seeing, severe coronary disease and aortic insufficiency. So she's in a lot of trouble. But the good news is with very strong medications, we can really treat her. So I suspect there's not much left diagnostically to start to think about initiating treatment, except potentially to rule out syphilis. Yeah. All right. Let's hear from Ravi.
Absolutely wonderful discussion. So one more test to talk about. So there's this dark blood MRI, which allows you to blank out the blood and then look at the vessel, because the vessel here was pretty much screaming pathology, and it showed a lot of pathology in different spaces. So the left common carotid artery, wall edema in the aortic root, ostium of left main coronary artery, proximal ascending, descending aorta. Post-contrast MRI showed wall enhancement in the ascending and descending aorta and periaortic tissues. And so this is compatible with the aortitis and active inflammation. And a rheumatology consult was obtained. Oh, the syphilis STD panel was negative. Thinking about that was a good call, Rabi. And rheumatology saw the patient and said, this is pyoderma gangrenosum supporting this underlying systemic inflammatory process. And the diagnosis was Takayasu's arthritis with a very abnormal presentation. There was no discrepancy between the peripheral pulses in this patient, so a very atypical kind of a presentation. So following a multi-D discussion, patient was treated with high-dose steroids, immune modulating therapy, and was closely followed. There was also concern with this left main coronary artery narrowing. She would likely need CABG in the future and was restricted from athletics. And about 4 months later, the pyoderma gangrenosum had resolved, and she was stable on prednisone, tocilizumab, aspirin, metoprolol, clopidogrel. PET stress testing was performed, and it showed then no flow-limiting coronary artery disease. It resolved, was able to resume limited athletic participation with restrictions on competitive play, and a repeat left heart cath was planned and is pending. But if this was not treated, say she didn't come in, she would be at high risk for some cardiac death. So that's the case, and thank you for discussing.
Ravi, this is an unreal case. I think there's so much learning to be had. I'm curious what reflections you have, Aaron. Maybe we can hear what your reflections are, Ravi.
Yeah, so thank you for this case, Ravi. I'm also really glad there was a happy ending to it. So it seems like the patient got very well after this, and she's just undergoing monitoring. But yeah, this was a fun case. I was really scared in the beginning because of all the acne stuff. I was like, oh gosh, Ravi picked a derm case for me, and I was like, I don't know. So if anyone knows me, they know I hate eyeballs and skin. So those are like my weaknesses. And then the giant rash on the PE, I was just like, oh gosh, I need to really work on my skin exam. So yeah, and Dr. Ravi did a great job of guiding me through the whole um, case. So yeah, it was a great time.
Aaron, wasn't it amazing how hard it was to know what the problem was? And then once we knew what the problem was, aortitis, it was effortless.
Mhm.
And I think that sums up clinical reasoning for you. If you know what you're trying to solve, it becomes much easier. The hard part is trying to figure out what the issue is. And I'll guarantee you that unless this patient is in the care of Dr. Ravi or his colleagues, many patients like this go underdiagnosed for a long period of time. And in fact, I can tell you for sure, based on how much stenosis she has in her coronary osseous, she's had this condition for years, right? And it's such a difficult diagnosis to make. And so, yeah, I would say the learning from this case is not the diagnosis of Takayasu's, it's the incredible journey that Ravi gave us the opportunity to go on, to go from acne all the way until, oh, wow, your proximal aorta is in trouble. And I think hopefully people learn a little bit from that journey. And I'd emphasize this is not about the actual diagnosis here. It's really about being very methodical about the journey. So really appreciate you, Ravi, for that opportunity. And curious what reflections you have from this case.
Oh, no, absolutely a joy to present and also give this case to Aaron, because he's presented so many cases to to us on Tuesdays. So I really appreciate you leading through methodically, anatomically, because the next patient that comes through the door may have something else, right, within that space of the chest wall that you nicely had laid out. I think, like you mentioned, from the first aliquot, that really hit home. Uh, Young people coming to the emergency room with chest pain tend to get dismissed, and which is called medical gaslighting. So putting their complaints to the side, and because sometimes we're limited, but this case really does hit home that young people can carry very, very severe pathology. And so coming here, listening to these cases, we build a list of experience and differential diagnosis. So appreciate your time.
I appreciate yours, and what a great, important to reemphasize to keep your eyes open for young people presenting with chest pain. It's definitely have to have your antenna. Vinny, we've been waiting for an hour for this moment. Mike, to you, my friend.
Yeah, so phenomenal case. I would say that our tremendous job. It was hard. Yeah, I've been in your shoes when you have like um, a difficult derm case or plague and everything. It's hard to describe, but well, anyway. So the patient initially presented with chest pain, and we need to rule out life-threatening etiologies first. And 10% of the patients that present to the ED uh, with chest pain, and they are from a young population, and we need to see if the possibility about congenital heart disease, traumatic, autoimmune, spontaneous pneumothorax, ACS, aortic dissection, esophageal rupture, cardiac tamponade, and so many other etiologies. And the patient was revealed to have a rash, and the rash was considered like a plague. And by definition, we can consider that as a flat topped, raised more than 1 centimeter lesion. And they had a mild fever in the context of chest pain, and it was at that moment that the differential diagnosis starts to narrow, and we need to know that the lungs doesn't hurt, but the pleura, yeah, the pleura, yes, and it could be a pleuritis or pleural irritation, and if the inflammatory markers were to be negative, and we will need to question if the fever was real. In the end, a bunch of tasks could be done. So it was discussed about the PPV of Echo and Angel and CT Angel in the for this patient. You can do the Echo for initial triage, but it will need further imaging in the end. The patient was revealed to have a aortic regurgitation, and the differential diagnosis is narrow even more. So we will prioritize endocarditis with blood cultures, and we'll see about any kind of pattern of LV dilation and function versus functional regurgitation, and we'll consider intrinsic and extrinsic problems of the valve, and we'll see about the perfusion of the coronary. So you can have an anatomical proximity. The lesion could have an anatomical proximity, and you can also have like a thromboembolism perfusing the coronaries. So in the end, the patient was revealed to have a erythritis, and then syphilis was ruled out, and then autoimmune is the big picture right now. So you need to consider mainly large vessel vasculitis. The patient is not in the age or in the epidemiology of GCA. So with legs is to investigate Takayasu arthritis, lupus, and so on. So Takayasu was investigated, and fits a young woman pattern, and it is kind of considering the boards of the Bushell's disease. And well, it had a happy ending. We can say that she had a tremendous follow-up, and well, phenomenal case. Thank you so much.
I love it when we have the return of the seasoned legends to set the standard for teaching points. Yet again, Vinny, that was absolutely outstanding. A really nice recapitulation of the whole journey. Mohammed, you had a difficult job today with a lot of scribing and a lot of data. Thank you so much for doing it so well. And big shout out to you, Aaron, for congrats on your first case discussion. Now we got to bridge the gap between your case discussions and presentations over the next hopefully 10 years or so. Uh, and big shout out to Dr. Rabih for such an awesome case. I just wanted to end by emphasizing that like the VMR tomorrow is at the same time as it is today, a little bit of a shift from our usual habits. And Aaron, you'll maybe, if you're available, get to see me shining tomorrow with the case from Zachariah. So hope to see some of you then. Bye, guys.